I'll go simply through it about the evidence and the hypothesis behind this intervention with some of my cases just for illustrations. About left main intervention, the debate for a very long time, is it for PCI or CABG? This slide is concluding most of the biggest randomized trials, Syntex, Nobel, ProCompet, and Excel. In these trials, usually it's not that difference between PCI and CABG outcomes. They share the same mortality, stroke and myocardial infarction. And in some studies, PCI is preferred due to few peri-procedure complications, stroke, myocardial infarction, and more rapid recovery, as we all know, and lower 30 days MACE. Where CABG is preferred as it has fewer adverse effects behind 1 year, so it's somehow more durable. This slide, a very recent review just from 2 months ago, dealing with the debate left main for CABG or PCI, and it prefer to share the patient preference as one of the main cornerstones for choosing the treatment option. For the one who would like to be restricted to the guidelines, this is the guidelines, and it's simply left main interventions with low and intermediate Syntex score. CABG and PCI doesn't differ, but in patients with high Syntex score, of course, CABG is a preferred option. Indications of left main stenting, as we all know, lesion more than 70%, minimal luminal area by IVUS less than 6 millimeter, and FFR of less than 0.8. And in this picture, this is the minimal luminal area that should be achieved after intervention. It's 8 millimeter in left main. When we make PCI planning, it should be done for any PCI, but in left main, it's very important. Pharmacology, you have to use intracranial nitroglycerin in any left main intervention to assess the lesion first. Access, it doesn't differ. We can make complex left main interventions via radial or femoral approach. Engagement with catheters, there is some evidence preferring a Jotkin left than ABU, as with Jotkin left you can easily go deep through and out than with ABU, but both can be used. You have to wire both LAD and LCX, whatever the technique you are using. Imaging with IVUS is crucial, and determine your target lesions. Lesion preparations, if we have calcium or a big arc of calcium, we have to crack it, and if you have a tight lesion, we have to pre-dilate it. Then you are supposed to choose your stenting strategy. Provisional is the best one, but it's not the case with every case scenario. Sometimes you have to do a bifurcation or even a trifurcation. The key principles of left main stenting include 3 very important factors: wiring both vessels, especially securing the side branch, POT, and IVUS imaging. POT optimization is very important in doing left main. Why POT is needed before side branch wiring? Because if you didn't make POT before side branch wiring, you can go with the second wire behind the stent, and if you push a balloon, it can destroy the main stent. When planning for unprotected left main, this is the most 3 important questions. Does we need hemodynamic support or not? What about lesion preparation? And what will be your stenting strategy? Let's begin with the first one, hemodynamic
Mahmoud,
support.
If we add the imaging, Bardo, if you, in these points, imaging,
yes,
either IVUS or you will use in some cases, definitely, not all cases, but this is one of the more important when you are planning to do unprotected.
Yes.
Sorry for that.
Hemodynamic support, a lot of cases is not clear for a lot of cardiologists. Do I have to prepare with pre-planned cardiac support or not. These items in front of us, if you found most of them, you have to prepare yourself with a hemodynamic support. If you have RCA disease, unprotected left main, low ejection fraction with high filling pressure, coexisting valvular heart disease, right, severe aortic stenosis or severe mitral regurg, complexity of planned procedure and complications. Let's take a case for illustration. This is a 75 years old female patient, diabetic hypertensive, presented with accelerating angina, ejection fraction 25. She has a multivessel disease, left main, mid LAD, total LCX, and subtotal RCA. So this case is covering most of the items in patients that need hemodynamic support. So I have ordered for intra-aortic balloon, which was the hemodynamic support available. ليه ما بتشتغلش؟ هو شغال عندي. Okay. Here is a left main with LAD and total LCX. Also, the RCA is diseased. Okay, this patient has a total LCX CTO, so the main vessel that will be done is the LAD and side branch is the diag. Just wiring the LAD and the diagonal with the first PCI. Just after first balloon inflation, the patient has no reflow and patient arrested. Resuscitation was done and intracoronary adrenaline was given and the stent was put in the LAD with TEMI 3 flow. And then the other stent in left main. And this was the final result of the left system. So this is just for illustration that in this patient, we suppose that we have this problem and that we need hemodynamic support. And even this patient, when I completed to the right, just by the first PCA to the right, the patient also arrested and have no reflow. So we precipitate these complications. This is very important. We can go to the second question, do we need lesion preparation or not? The first, very important, is how about calcification? As we can see, this is a case of complete arc of calcium. This patient is 80 years, old gentleman, known to be hypertensive, not diabetic, non-smoker. He was presented by dyspnea, angina equivalent, NIHA class 3. Echo was almost normal, hypertensive heart disease. And I sent him for multi-slice CT, and I was surprised that I have a calcium score of 8,000. I never heard about this number, either before or after. When I go for angio, هو الفيديو ليه ما بتشتغلش؟ Okay, this video is not working. This patient has complete arc of calcium by IVUS in the left main and mid subtotal left main. So I have went for this patient for rotablator with 1.75 BER. Sorry, this video is not working, but as we can see, this is the BER. سلايد بقى بعدين.
هو باين الكالسيوم كمان راسم البيسل.
مش عارف ليه الفيديو مش برضه مش شغال. Anyway, it has subtotal complete arc of calcium rotablator. Then I have put a stent and make it as a bifurcation of left main and this high of calcium. And this is a follow-up cryo-angio after 3 years showing a patent stents. Yes. Yes. And this is the result. So when using a rotablator, it gives a long-term good results. Okay. Third thing about stenting strategy. Stenting strategy differ according to in which area of the left main you have the lesion. Is it ostium and body or distal lesion? Distal bifurcation lesion in left main is about 80% of the cases. Let's begin with aorto osteal lesion. We have two challenges: pressure damping and stent positioning. If you are going to an osteal left main, you usually will see this view where you have a pressure damp. So don't inject if the pressure is damped. Use nitroglycerin, minimize injections, ensure contrast clear, and optimize angles. This is also a case of osteal left main. Just one cannulating the left main pressure damped by this way. انتوا بوظتوا لي البرزنتيشن. كل الفيديوز مش شغاله.
باين مفيش لازمه على الليفت يمين.
This is okay. Okay. This is not a spasm. This is a significant lesion. So when you have this case, there is prevention and treatment. You can do it. It's one of these four: intermittent guidance age.
ماشي الكالسيوم بتاع السكند
يا جماعه
دكتور محمد عبد
دكتور
الغني
محمود،
مرحب بيك.
لما الدكتور محمود يكمل راح الدكتور محمد عبد الغني الاول ونفتح ديسكشن بسيطه. هتبدا ولا لسه؟ انا كنت بقول الليفت مين انترفنشن هل ينفع اخليه اتس بريفرنس اوف ذا بيشنت اونلي؟ لان دي حته في منتهى الاهميه البيبر اللي حطها. هل قرار الليفت مين انترفنشن سواء انترفنشن او جراحه هل اعتمد على رغبه العيان بس؟ دي اعتقد يبقى لازم ديبيتابل مهمه بعد البتاع، لان ساعات رغبه العيان ما بتبقاش صح.
هي دي البوينت ان
بتتكلم على بروجنوزس وبتتكلم على ديفيكالتي وحاجه تستخدم فيها هاي ريسك. يعني العيان اصله مش عاوز يفتح صدره بس يعني معنى كده ان هو يقول اللي هو عاوزه.
في جايد لاينز هتساعدنا اذا كنا نوافقه ولا لا.
استخدمتها اشتغلت.
بتكلم على الديستال ليفت مين مش على البوكسمال والميد ليفت مين زي ما قال الدكتور محمود.
Okay, I will stop here about the damping of pressure in this ostial left main. So you can use intermittent guiding engagement, load the wire in the cast before engaging the left main, and then put the wire and disengage the guiding like this. Or you can use a child in mother caster. Floating wire is one of the techniques preferred. It's good for two things, for keeping the guiding away and for positioning of the stent, because positioning of an aorto ostial stent is left main is one of those challenges. The best thing is to have 1 to 2 millimeter outside the left main, and this can be adjusted well with this technique of marker wire. This is an aorto ostial left main case also for illustration. Direct stenting provisional for left main in this case, but as we can see, we have some compromisation in the ostial LCX. So I have done for it a kissing, and after kissing, we have a good result. What about kissing in provisional stenting in left main? It's controversy. Kissing balloon in provisional stenting, there is some data supporting it and some data against it, but in our case, it has a good result. This is the final result. One of our other problems is when putting an aorto ostial is to miss the ostium or have excessive stent overlap or have an underexpansion of recoil, as we can see in this other patient, case 4, stent underexpansion, as we can see at the mouth of the stent. And then we have done PCI and see it like this, it opened well. So it's very important to check for that. And then we check by IVUS. And this is the final result. What about challenges in distal left main interventions? Either it's bifurcation or trifurcation, or when having an acute Crohn syndrome. This slide is very, very important. It covers most of the techniques used in left main interventions, as we can see. If you are not afraid to have a side branch occlusion, you can go directly for provisional stenting, and this is shows the best outcomes. If you are afraid to have a side branch occlusion, you can go for V-stenting simultaneous or tap and DK crush and clot. I prefer tap and DK crush. It can cover all angles and all techniques and all patients, even in left main intervention. You don't have to use some techniques outside it. This is a case of distal left main Medina 111. We go through it by a DK crush technique. As we know, all have put a stent in the side branch, then crush it by a balloon. Then kissing, rewiring and kissing, and then the stent in the left main. Sorry, pot and the final kissing. And after the second kissing, we have to make pot again.
This is a 5 balloon. This is 5 or 4.5.
Yes. And this is the final result of DK crush. another challenging case, and this is very important. When you have, it's not common, but we have seen it a lot. When you have a primary PCI for a left main containing thrombus, what to do? According to the previous slide, here the algorithm recommends simultaneous V stenting. But actually, this is an example of case that I have used something different. This is a case presented with acute myocardial infarction. As we can see, we have a big thrombus burden in distal left main and osteal LAD. And also the osteal LCX is compromised. We are Medina 111. So here it's very important that if we go for traditional ways in left main bifurcation, so DK crush or even tap, just by doing kissing, 90% you will get an overflow phenomenon. So in this case, I preferred not to use V stenting. I don't like this technique a lot. But I went for provisional stenting. And I know I'll have Zanapot, and I know I'll have compromised LCX. But as we can see, after a provisional stenting, we have chemistry flow in left main LAD and LCX. And I put patient on tirofiban and to complete it by tap technique after 2 or 3 days as a bailout technique. After tirofiban is given and to reduce the thrombus burden, so we can go for stenting and kissing safely. So we have to reduce always PCA in thrombus burden. The last challenge is about trifurcation. I want to go rapidly. There is a very important thing we have all to know about trifurcation. Not all left main trifurcations are true trifurcations. It's considered true if we have one of these 3. We have 3 branches affected. All these yellow labels are not a true trifurcation, and we can solve it easily with a simple bifurcation technique. This is the only big registry about trifurcation. As we can see, if you have a true trifurcation left main affecting the 3 vessels, you have the worst outcomes. But if it's not a true, like the green line, you will have better results. Not all trifurcation lesions are the same. Extra backup by 7 or 8 French is important. Wiring all branches. Lesion preparation is very, very important. IVUS is mandatory. Consider hemodynamic support as needed by the previous indications. Depending on the lesion and the anatomy, you can choose your strategy, either single, double, or triple. And you have always to keep in mind that lesser stents are always better. Trifurcation lesions is about 10 to 15% of all left main diseases. Pre-dilatation crossing to the stent is very important. All bifurcations technique can be used, and we can need innovative. We can use this nice word tracing balloon in spite of kissing, and less complex techniques usually get best results. When you have a complex left main through trifurcation with high Centex score, this is the worst case scenario where intervention by PCI is not recommended at all. Last case scenario, this is a case with, as we can see, osteal left main tight, and Dr. Ibrahim knows it well. I give nitroglycerin, and after nitroglycerin, I have the same picture with tight osteal left main. Dr. Ibrahim asked me to do direct stenting, but I prefer to use an IVUS. And actually, when I used IVUS, I found the minimal luminal area around 12 millimeter. So it's not a significant lesion. And I ended by that without stenting. In conclusion, unprotected left main interventions need proper planning and good anticipation for challenges. Damping of pressure is very important and tricky and need special maneuvers. IVUS is critical in most of left main interventions. Lesion preparation and mastering at least 2 bifurcation techniques is mandatory. If possible, laser stents are always better. And thank you.
Thanks.
ثانك يو دكتور محمود. مش معنى ان انت مدير المؤتمر تاخد نص ساعه لحسابك. ثانك يو.
ما قدرناش نكلمه.
هو بس
بقول لك هو مدير المؤتمر
هو كان في ديلي بس
فما اقدرش اكلمه، لكن هو عمل جود ادمنستريشن difficult cases in general. طبعا اهنيك على البرزنتيشن وعلى الديمونستريشن في tough cases. لكن خلينا نتفق على حاجه، يعني حابب اشارك الاخوه الزملاء لان كله انا شايف اساتذه تقال برضه في الانترفنشن. احنا هل ينفع ان انا اخلي الليفت مين انترفنشن elective cases، بتكلم على elective cases as a patient preference only ولا في كرايتيريا ثانيه؟ دي مهمه قوي، دي نقطه مهمه. النقطه الثانيه زي ما قال الدكتور عمرو في الالكتيف كيسز، هل المفروض يبقى في ايمجنج ولا لا؟ دي في منتهى الاهميه برضه، لان انت الحاله الاخيره طلعت سبازم او طلع كلام فاضي يعني، صح؟ ودي على فكره بتشوفها كتير.
والحاله اللي كان فيها
الاوستيال
بتاع
عملت
الستنت
ايبس
قافل.
ما كنت هتحط لها ستنت طبعا. الحاجه الثالثه والمهمه قوي انت قلتها في حاله الجلايكوبروتين 2B3 انهبيتورز، لما الاقي تم فلو 3 انا متوقع ايه من الجلايكو 2B3 2 انهبيتورز واسيبه يوم ولا يومين؟ انا I think it is doughty effect حب يعني. انا دونت بليف يعني حتى الجايد لاينز كده.
It's just for preparation.
يعني الثرومبس بيردن سنس ان حطيت ستنت وما فيش نور فلو، في الغالب الامور البلاك شيفت اعلى من الثرومبس بيردن. فدولك 3 بوينتس. طبعا حالاتك كلها انت جايبها كبار وكلهم كالسيفيكيشن وبتاع، فربنا يعينك يعني. فنحب نسمع راي حضرتك الاول بعدين راي الناس.
هو بالنسبه للبيشنت بريفرنس طبعا it's one of the criteria, not the main cornerstone. And regarding IVUS, my preference is to do IVUS on all left main interventions because some of these cases like osteal non-significant left main, stent not expanded well, and there's a lot of pitfalls you can go through without IVUS. The third thing about the glycoprotein 2B inhibitors, I use it in this case to prepare it for doing the complete bifurcation technique after 2 days. So it is just a pre-hoc to, if I won't do it, I will not put the glycoprotein 2B.
يعني انا في تخيلي لو انت عملتها بعد يومين على ابلابكس واسبرين هتلاقي نفس النتيجه.
I think it is tailored according to each patient. لو كنا شفنا بقيه الموفيز وكده او الصور اللي كان واخدها كان هيبان في ايفيدنس اكتر يدفعه ان هو يستخدم الجلايكوبروتين انتاجونست وبالتالي يعمل بريبريشن اكتر يعني عشان يحسن الريزلتس بتاع السكند انترفيو. Any questions from the ground?
Okay, because of delay, we have now online with us is Dr. Gabriele Gasparini. Gabriel, are you with us?
Yeah, hi, I'm Haman. How are you?
Do you hear us, Gabriel?
Yeah, yes, I can hear.